Good evening, everyone. Thank you so much for joining here today. I'm Melek, an economist and researcher with a strong dedication to health-related issues. I actively contribute as volunteer for Lupus Ontario for Education and Awareness Department, focus on increasing awareness through social media platforms. Firstly, I would like to thank Roche, our presenting sponsor, for their support. So thank you so much. I would like to introduce our speaker for tonight. Is Dr. Murray Urowitz. First, I will start to do introduction of Dr. Murray, and then we're gonna continue with his presentation. So Dr. Murray is a professor emeritus with Thermative Faculty of Medicine, University of Toronto. He was the director of the Center for Prognosis Studies in the Rheumatic Disease Toronto Western Hospital from 1995 until 2022. And he was the director of the Toronto Lupus Program from 1970 until 2022. Dr. Urowitz is he established the University of Toronto Lupus Clinic and Lupus Database Research Program in 1970. He has supervised for training over 130 fellows in rheumatology, especially in SLE. And Dr. Urowitz was founding member of the Ontario Lupus Association that now is Lupus Ontario. In this session tonight, Dr. Murray will provide a brief recap of types 1 and 2 lupus, followed by an in-depth exploration of lupus types 3, 4, and behind. He will discuss the implication of those classification on ongoing lupus patient treatment, and he will provide some insight on how patients can effectively advocate for themselves as their disease evolves. This session tonight aims to equip lupus patients with the knowledge and strategies to engage proactively with their care practitioners. Welcome, Dr. Murray. Thank you so much, and you can go ahead now, please.
Well, thank you, and thank you to all of you online who are willing to stay up late and give up your after-dinner drink and participate. I'm happy to be here with you. You just heard a wonderful presentation by Laura on the new therapeutic approaches in lupus, how we treat with people once we've adequately diagnosed them. My job is to go down to the individual patient. We're going to say, well, what does lupus really look like? We always said lupus is a very heterogeneous disease. That was really not describing the whole picture. It is even more complicated than that. And therefore, it's very important for you, the patient, as well as the physician, to recognize the multifactorial issues in a lupus diagnosis so that you can direct therapy appropriately. And the therapy for each of the different types of lupus is different. And that's my job tonight. I want to talk to you about phenotyping the disease, describing the various different presentations for this disease. Which lupus do you have? Can you see this screen? Is my screen visible? Somebody
yes,
say yes.
Doctor.
Okay.
Yes, Doctor. Thank you.
Thank you. So when I say which lupus do you have, is you and the physician have to approach your condition with open eyes. If you look only at one aspect, you're going to miss something very important, the big picture. And what I want to do with you tonight is talk about the important other aspects other than the usual aspect we've been talking about for years, and how it impacts our diagnoses in the plural, and the approach to the patient. So how do I describe thee? Let me count the ways. With apologies to Elizabeth Barrett Brown. So tonight, I want to talk to you about 4 types of lupus. And you may have 1, you may have 2 or 3 or 4 all at the same time. And your major symptoms may be of one of the types, but the other types are there and may contribute to the symptoms. And it's very important to distinguish them. Let's talk about that together, talk about each type, and let me show you how they interact and overlap. First, type 1 lupus is something that you all know about. It's what Laura talked about in the first hour entirely. The thing about this condition, we'll show it about briefly, is that it's due to inflammation, due to an immune abnormality. So it's an autoimmune inflammation. And the features of type 1 lupus all respond to standard immunosuppression. So whether that's prednisone, Plaquenil, the biologics, the standard immunosuppressives, etc., they all respond to a greater or lesser degree. That's the classic lupus. So you know that it has arthritis, there's rash, there's cutaneous ulcers, there's alopecia, that's hair loss, inflammation of the lung lining and the heart lining, muscle inflammation, destruction of blood cells, and then neuropsychiatric lupus. Now, you all know that each one of these individual categories can occur, but they can also coexist and interact, and you can have multiple categories at one time. And you know, this came out in these new EULA. This is the EULA or ACR, the two agencies together, set a new set of criteria for lupus. And Laura just alluded to that very briefly at the beginning. These are all the classic features that we talked about here. And in order to make a diagnosis of type 1 lupus, you had to have a positive ANA test, according to this. If you had a positive ANA test and a series of these manifestations, you could possibly have lupus. And you can see the manifestations each have numbers associated with them, which reflects their severity. So the kidney one gets the highest number, and then the other manifestations have slightly lower numbers. If you get a score of 10, you add up to 10 here, and you have a positive ANA, you have lupus. Now, you could have 10, you could have 20, and they're going to be different. The 20 is going to be a much more severe form of lupus than the 10. But all of them are lupus, mild or severe, single organ, 2 organs, or multiple organs, all possible. So that means it's a heterogeneous disease. But now what I want to tell you is within each of these features, there is phenotypic heterogeneity. Even the features are different, and they have different mechanisms and therefore may respond differently to therapy. Let me show you. Let's take skin for a minute. So this is a woman with lupus, and you can see here she has a rash on her face and up her chest and neck. The rash is in the butterfly area, but even more wider than the butterfly area. Look, this sparing here of this nasolabial fold is here, no rash there. That's very typical of acute cutaneous lupus. This looks terrible, but I can tell you when we treat this woman, all of this will go away and her skin will be absolutely normal. So it looks terrible, but very responsive to therapy, acute lupus. This is chronic lupus or discoid lupus. Now here's a man who had a butterfly rash. You can see here, and over his nose, classic rash, but this did not go away when it was treated. It was left with scarring, and it was left with hyperpigmentation. So yes, he's got dermatitis or a rash, but his is much worse. And the mechanism, the type of inflammation in the skin is very different than the first one. The treatment may be different than this, and it's important to institute treatment early here if you have chronic or discoid lupus, because if you don't, you're going to end up with scarring. All right, so there's 2 kinds of lupus, acute and chronic. And then you have a third kind of lupus, which is called subacute lupus. Remember, this is one organ. We're talking about skin, but I've now shown you 3 different kinds of skin. Here, this kind of skin involvement, subacute lupus, has 2 varieties. One is a scaly kind of rash, like here. Looks like psoriasis, actually, here, scaly. And the other one is circular red area with a pale center. This patient very nicely, conveniently showed us both rashes of lupus here, subacute lupus. This lupus is associated with a specific antibody called anti-Ro antibody. It's very sun sensitive and it responds to therapy. It will go away with therapy, but it will leave perhaps hyper or hypopigmentation. So does some darkening of the skin or some lightening of the skin can occur, but not damage to the skin like the chronic kind. So I've shown you a rash, but there are 3 different rashes, each of them different, and each of them may respond differently to therapy. There's another kind where you have actual a rash, which is and this is probably due to inflammation of small blood vessels in the hand and the fingers. This rash actually leads to sloughing of tissue. You actually lose tissue here, right? So again, another rash, but and classified as rash, but with different mechanisms and different response. Now, here's another consequence of rash which you don't see. In the skin, there are a number of appendages under the skin surface. There's the hair follicle, there are mucus forming organelles under the skin. If there's inflammation under the skin and that inflammation surrounds a hair follicle, the hair that's produced by that follicle will be weak. So as that weak hair grows out, as you lie down on your pillow and move your head side to side, the hair that's weak will break off and clutter your pillow, right? Or, of course, if you run a brush through it, that weak hair will break off and you'll have a brush full of hair. This gives you the condition alopecia, which is baldingness, right? Becoming bald. And this is diffuse alopecia. And sometimes it's only localized in one area or 2 areas. Again, some skin involvement, but giving you hair loss instead of the other things that we looked at. Well, in addition to the outer skin, there's the inner skin, the mucous membranes in your mouth and nose and your vagina, etc. That's the inner skin. You see, this is a patient with lupus. You see, she has a butterfly rash. You see, she has nasolabial sparing. Remember, I told you this white area running along this area? It's clear lupus. But look at her mouth and her hard and soft palate. She's got these sloughing of the tissues, these ulcers, mucous membrane ulcers. Now, the problem with this is if a lupus patient has a mucous membrane ulcers, 50% of them will be very painful, and the patient will come in and say, "Oh, I got such canker sores in my mouth. I can't swallow. I can't. It's really bothering me." The other 50% are totally asymptomatic. The patient doesn't even know they have them. And so if the doctor doesn't say, open your mouth, say, and look in and look for mucous membrane ulcers, they'll miss them. Okay. So that's the inner skin, the mucous membrane ulcers. I'm showing you heterogeneity within one kind of organ involved. Now, this is a very typical one. This is arthritis. And here, just like in rheumatoid arthritis, you can have swelling in the small joints of the hand and metacarpophalangeal joints here. The patient will complain of severe pain and maybe even puffiness of those joints. But the difference is they never develop damage in the bone. The bones remain absolutely normal. That's not what you see in rheumatoid arthritis, where you see the tissues, the lining of the joints actually invading the joint and causing the joint to be damaged internally. You don't see that in lupus. But occasionally you see this. Here's a man with lupus. I told you they don't have damage to their bone. They don't have deformity. But this man does have deformity. You see his fingers are drifting over to the side, more on the right than the left, but a little bit of a drift. What's happened here? the X-ray showed the bones to be normal. What's happened in this man is the tendons which run down over the top of the wrist and into the finger are tethered down here with little fibers, and they're held, and when they're tethered down, they hold the finger straight. When this becomes inflamed, that tethering, that tying down of this tendon gets loose, the tendon slips, and it slips over here into the crack instead of lying on top. And so when you make a fist, it pulls the fingers over to the right. So I told you that lupus arthritis doesn't give you damage. You're right, it doesn't give you bone damage, but it certainly gives you tendon damage that can result in this kind of drifting of your fingers. This was originally described by a French physician, Dr. Jacquot, in patients with acute rheumatic fever. So it's called Jacquot's arthritis. But this is a lupus patient with this kind of arthritis due to tendon slippage, not due to bone damage. Then, of course, there's inflammation of the lining. Here's the lungs. There's the lining of the lungs. And this lining can become very inflamed. And if it's very inflamed, it can even exude fluid, which will accumulate in the lining area here. And that's for the lung. And the same thing can happen to the lining of the heart itself. Okay, so if you've got chest pain, the doctor will have to differentiate between inflammation of the lung lining and inflammation of the heart lining. Now, one of the most difficult one, and Laura's talked a lot about the kidney involvement, is you can say the patient has nephritis. They got protein in their urine, as she described, and their EGFR may be falling, but you don't know exactly what kind of kidney inflammation they have unless you do a biopsy. And if you do a biopsy, you will find that there are 6 different patterns of damage and inflammation in the biopsy, in the kidney biopsy, and they will have a different long-term outcome, an impact on the patient. So it's not enough to say, oh, the patient has nephritis. You have to say the patient has nephritis, and my biopsy showed that he has class 3 or class 4, because that'll help determine what treatment they really need. So nephritis is not enough, subdivide it. I've shown you a picture here. This is a glomerulus, a little circle where the tubules, which take the urine into the bladder eventually, are open and allow the urine to be formed and to exude down into toward the bladder. Here you can't see any openings. This is all clumped together, and here's a worst case. So you can see this inflammation is clogging up the kidney's ability to function normally. This, however, is a different kind of nephritis. This is class 5, where the tubules are empty. You can see the openings, but they're surrounded with a thickness. So this thickness impedes the function of those open tubules. So you can see this is very different than the last one that I showed you. And if you don't do a biopsy, you'll never know which one you're dealing with. And of course, with central nervous system, we could spend the next 3 or 4 hours. You can present with headache, with psychosis, with a stroke, with visual disturbances or cranial nerve disturbances, or cognitive dysfunction, that is, inability to reason normally. All of these things could happen. All of them are a feature of central nervous system inflammation, but they can vary, and a patient may have 1 and 6, or may have 2 and 1. So again, there is heterogeneity within each manifestation. So again, I point out, it's not enough to say they have neuropsychiatric involvement, it's which one is it? And that tells you a little bit about how it's caused and how you're going to approach your therapy. Okay, so these are the features. But how can these features present over time? Does a patient get 1, 2, 3? What happens over time? The patient may have something when they present to you, but what does their course look like? So we were able to show that lupus runs at least 3 different courses. One is called relapsing remitting, and this is the most common. What is this? The patient comes in, they have a flare up of their lupus, come to see the doctor, they get some treatment, hopefully successful, and they go into a remission. And then, unfortunately, they have another relapse and do the same thing again. Relapsing, remitting. Okay. The second kind is the kind that we dread, the persistently active. The patient flares, and you treat the patient, but they don't respond. They continue active all along, or more and more. And these are the patients that often get into our studies. Patients who get into trials with new drugs because they have not responded to anything. Persistently active, we dread this variety. And then there's a variety that we all hope for every time we see a new patient. The patient has a flare, they go into remission, and they never flare again. Likely because we continue treatments, not cortisone, but the other treatments for a long period of time, and they remain clear, inactive, monophasic. So you've seen 3 different kinds of lupus. The new active, if a patient comes in and they're active and they're new, you don't know which ones they are. Are they this one or are they the other one? You're going to have to follow the patient to find that out. If the patient comes to you and they're persistently active, you say, oh no, I've got one of these. And I better start looking for new trials that I can enter this patient into. Or if the patient comes in and say, Doc, what you did was really good, and I'm feeling better. So are they here? Or are they here? Well, time will tell. And if they come in frequently saying they're better, you can say, I've got this patient in remission. So those are the 3 kinds of courses that our patients with these multiple symptoms can enter. Okay? So if I told you there were the 3 kinds and I said that all of them have some active disease, look at here. The monophasics just have active disease in the beginning. Active disease is pink. The relapsing remitting have active disease half the time. And those poor, persistently active have it all the time. So in our lupus patients, we're always treating pink. Active, active, active. Those are the ones that are going to present to us. We have to figure out which one of these are they and begin treatment and monitor them appropriately. Okay, so what I've shown you is there's heterogeneity within heterogeneity. Which organs you have are very different among patients, and within one organ, there are different presentations of that organ system. But all of them do respond to immunosuppression. That's the lupus that you've known for a long time and that we've known. The new lupus that's now becoming more prevalent that I predict will have a lot of investigation done in not too distant future is type 2 lupus. What's type 2 lupus? Number one, it's not inflammatory. It has nothing to do with the immune response as we understand it. It's not due to inflammation, and therefore it doesn't respond to immunosuppression. Don't let yourself be dragged in. The doctor say, oh, your joints hurt you. Here's the prednisone. It may not be the prednisone that's necessary. As a matter of fact, prednisone may be harmful. So what is type 2 lupus? Type 2 lupus has a series of new features. One of the most important features of all is fatigue. I don't mean just I'm tired today. I mean overwhelming fatigue that takes over your life. The second one is brain fog. I can't think clearly. I can't do like I used to. I can't keep my checkbook. I can't make a grocery list. Brain fog. The third one is widespread diffuse pain. But remember, I said not inflammation. The pain is not due to inflamed joints or tendons. This widespread pain, which is associated with tender points, the doctor can press on these areas and you will jump off your seat. So widespread pain and very tender specific points are all a diagnosis of fibromyalgia. Fibromyalgia can incapacitate a patient, but don't you dare give them prednisone or Imuran or mycophenolate, etc. That is not a treatment for this at all. Okay, cognitive dysfunction, not being able to reason properly, that's a worse than brain fog. Here, you're actually put to test and you fail. Sleep disturbance. People can't get a good night's sleep. They wake up in the morning just as tired as they went to sleep. And then psychiatric problems like depression and anxiety. All of these are type 2 lupus. They can occur singly or in combination. They are not due to inflammation, and they don't respond to prednisone or the other drugs, and they should not be given. So what causes that? Well, how do you deserve to have a whole new kind of lupus with a different mechanism? So we don't understand the pathogenesis yet, but there are a number of things that we can look at. You have all heard of long COVID. COVID, you get sick, you get fever, you get fatigue, you get aching, you get very sick, and then you get better. And those symptoms go away, and you continue then to notice brain fog, cognitive dysfunction, diffuse aching, and that's called long COVID. And there's another situation called chronic fatigue syndrome, where some of you may know that if you've had infectious mononucleosis, remember, with swollen glands and fever and aching, etc., you get over the mononucleosis and you're left with chronic fatigue and aching and brain fog. So what's going on? Here you get lupus, get over to lupus, and you end up with this type 2 lupus. Here you got COVID, you get over to COVID, and you end up with type 2 lupus kind of symptoms. Here you had an infection, infectious mononucleosis, a viral infection, you get over it, you got chronic fatigue syndrome. So somehow these insults, lupus, viral infections, trigger something in the body which give you these type 2 lupus symptoms, and they're not due to the original thing. They're not due to the original virus. The test for COVID is negative when you get to long COVID. So it's not due to the original virus. It's due to an effect possibly triggered by the virus, which now persists. And the same true for infectious mononucleosis. That's type 2 lupus. And you know, when a patient is asked to do a patient-related outcome, you know, they're asked to relate their disease according to 8 domains. Look at the domains that they're asked to talk about: their mental health, their role emotional, their social function, their vitality. What are they rating? They're rating type 2 lupus. So you have to be very careful. You don't say the patient has a very poor patient-related outcome, give him more prednisone. You got to be careful. If they're rating it because they're got type 2 lupus symptoms, don't give them more prednisone. Think about the type 2 lupus. And this poor rating is very bad in lupus. Lupus is worse than what you can get in heart failure, hypertension, diabetes, etc. Lupus with these type 2 symptoms is notorious. It's the leader in the field. Now, look, there is a discordance between the doctor evaluation and the patient evaluation. Please pay attention to this. Patients are interested in a number of things, and doctors are interested. I don't want to make a generic statement, all doctors. Frequently, this is a study, so I'm showing you a study. Frequently, doctors concentrate on what they know best: the skin rash, the kidney disease, the joint pain, the work probabilities. The patient looks at reduced ability to perform their usual activities of daily living due to pain, reduced ability to perform physical activities because of pain and fatigue, waking up feeling worn out, fatigue. Look at the difference. The doctor concentrates on this, the patient concentrates on this. We have to get together. Right now, the doctor focuses on type 1. The patient frequently focuses on type 2, especially in late lupus. We have to think of both. We have to work as a team. And we have to be sure that when the patient comes to see the doctor, that somehow that encounter is set up to elucidate both type 1 symptoms and type 2 symptoms, both, right? And then the type 2 symptoms, when they're assessed, they have to be addressed differently, not by giving more immunosuppressive therapy, but that may require lifestyle changes. So a social worker or a lupus nurse or a psychologist or psychiatrist, if they've got that cognitive dysfunction or brain fog. A neurologist may help in those areas as well. And then waking up fatigued with overwhelming fatigue and not being able to function, a sleep study may be very important, showing that the patient is not getting adequate sleep at night. So you have to work together, the doctor and the patient, and we have to evaluate type 1 and type 2 lupus. All right, briefly, type 3 lupus. What are type 3 lupus? So type 3 lupus is a consequence of the damage that happened from type 1 or due to the treatments for type 1. And there are 3 major features of type 3 lupus that have really overtaken a lot of the research in lupus now. First is the atherosclerotic vascular disease. Women with lupus, so I said women, young. If you say women and young, you don't think of atherosclerosis. Atherosclerosis occurs in older men first. So this increase in atherosclerosis in young women is very important. I'll come back to it in a moment. The bone disease, which you heard a little bit about, which I'll talk about in a moment. And finally, chronic neurocognitive impairment, this ability not to be able to reason appropriately. And we have to talk about that for a moment. None of these are treated with immunosuppression. This is damage. And some of this is caused by the immunosuppression, right? So this is entirely different. Lupus, important, not the same as lupus 1. So in atherosclerosis, there are a number of things. First of all, a number of our patients have atherosclerotic disease. Young women, okay? So when we looked for a while ago, in our first 1,000 patients, 10% of our patients, whether they were old patients or new patients that we're just beginning to see, 10% are going to have atherosclerosis, young and women. And atherosclerosis can become a heart attack, angina, a transient ischemic attack, a stroke, peripheral vascular disease in the legs, or sudden death. These are classic older man illnesses, can happen in young women. And the thing is, if you look, if we took our patients in the 70s, 80s, 90s, 2000s, when they first come, in the first 10 years, 9 or 10 years, they have about 1 in 10, as I told you before, will have atherosclerosis. But as you go to their next decade, when they go from 30s to 40s, it goes up to almost 17%. When it goes to 40 to 50s, 1 in 5 or more will already have had an atherosclerotic event. And if you go into the early 60s, a third of them will already have had an event. And this doesn't matter whether it was the old era or the new era. As you go further out in your disease, these events accumulate. So women with lupus tend to develop atherosclerosis, and it may in part be due to the lupus itself, damaging their blood vessels, or may in fact be due to some of the treatments, like the drugs that cause high cholesterol or high blood pressure or diabetes. Those drugs, by the way, are almost always steroids, right? They cause it, so they'll have the risk factors. All right, so that's there. That's incontrovertible. Everybody knows about it. So if everybody knows about it, why do we wait till it happens? Can't we figure it out before it happens and try to prevent it better? Like find it subclinically before it presents itself clinically. Well, I'm going to give you one example where we did that. We did cardiac screen uh, stress uh, uh, scans. So heart scans. So if you do a heart scan, what you do is you see the blood flow through the scan, and then you give them a drug which constricts the blood vessels, and you can see that they constrict normally. So you can say, okay, here's a blood vessel that's well functioning. If it gets something that needs a constrict, it constricts, but then it goes back to normal after. So these are heart scans. Okay. Well, look, we did a heart scan in 130 consecutive patients with lupus. They were 45, so that's young, right? You don't expect a 45-year-old woman to have the significant heart trouble. Now, of these 130, 13 of them had a history of coronary artery disease. So take them out. Don't consider about them. All of these patients had that heart scan I just showed you. Okay. Those who had no history of coronary artery disease, 35% had an abnormal scan. And this was a very important abnormal scan because it caused very significant constraint on heart function. So this happens before the patient has the heart attack and before the patient's developed angina. So shouldn't we be screening our patients very carefully? And of course, anybody who shows they're predisposed should be getting all the treatment necessary, keep their cholesterol low, keep their blood pressure normal, prevent diabetes, and make sure their lupus stays inactive to prevent a heart attack. So the heart attack clinically is only the tip of the iceberg. Now, let me show you one other very interesting thing that we found. We found sometimes these heart atherosclerotic events occur even before the lupus becomes obvious. So we did that in a SLIC cohort, and we looked to see there's a grower patients that we're following with a multinational origins, and they're all diagnosed within 6 months of being seen. So they're very early lupuses. We found that those patients, 23 of them, had a heart attack either before the diagnosis of lupus or within the first 2 years of diagnosis when they didn't have much time to develop it because of the lupus. But look, 16 had it before they even had lupus. Okay. So what does that tell us? Well, you could actually be born with that predisposition to have a heart attack, and your lupus is only going to manifest itself later. So what has the American College of Cardiology and the American Heart Association decreed now? And as of this year, as of last month, the European Heart Association has also decreed, if a woman comes into the doctor with a heart attack in her 40s or 50s, check them for an autoimmune disease like lupus, because it may be the first manifestation of lupus itself. Okay, that's the atherosclerosis. The second one is the bone disease, which you heard a little bit about. And this is almost entirely due to prednisone. So osteoporosis is when the bone gets very thin, and because it's thin and porous, it collapses. And osteonecrosis is when the bone is so thin that it actually dies. The end of a long bone actually dies, collapses and dies. So that's very severe bone involvement, usually not seen in people until they're significantly older. So here's a woman, you're looking now, you see this is their vertebrae, this is a lumbar vertebrae, and you see that this lumbar vertebrae is very thin, and you see it's already collapsed. It should be straight across here. You see it's already collapsed down. This is osteoporosis. with a vertebral fracture. Now, concentrate for a moment. See this. This is a leg and a foot, and this is a leg and a foot. Okay? This is the front of the leg, and the front of the leg, right here in the tibia, the bone in the front of the leg, has a fracture in it. And the bone scan lights up when you inject some radioactive material because there's a fracture in the bone here. And this same patient has a fracture in the second metatarsal down here in the foot. This is called a march fracture because recruits in the army used to get this when they went on their 20-kilometer marches. Some of them would come back with a crack in their metatarsal bone here. So this lupus patient has this fracture and this fracture due to thin bones. Okay. And then remember I told you about the killing the end of a bone. So here's a hip. And you can see that this part of the hip has actually broken off from the rest of it. The hip is supposed to be a ball and a socket. Here you can see the ball is actually broken down and is collapsing. And this is terrible because if this, when this happens, the ball and socket can no longer meet comfortably. The patient has severe pain and often has to have a hip replacement. And you're talking about a hip replacement in a 30, 40, or 50-year-old woman who's going to live another 20, 30 years with an artificial hip, right? And then this patient, you can see it's even starting on the other side already. So this is osteonecrosis, all due to the bone disease of lupus, due virtually entirely to prednisone. Okay, I'm just showing this the knee because it happens in the knee as well as it happened in the hip. All right, the final one is the neurocognitive impairment. This is, we know that some of our patients have organic brain syndrome, you know, where during their lupus, they're kind of wonky, they can't think clearly, then the lupus goes away and everything turns back to normal. But later on, this comes back again, much like the type 2 lupus I described to you before. And it's interesting, you know, because a while back, we took 58 controls who did not have active lupus, right? The controls, I'm sorry, were normal people here, normal people. And we took 58 lupus patients who didn't have active lupus. They were inactive. And when you did neurocognitive testing on those patients, the lupus patients had many more cognitive abnormalities than their matched normal people. So this is very important. You know, patients complain of this, and the mechanism of this is not yet clear. So that's type 3 lupus, right? And their comorbidities: heart disease, atherosclerosis, bone disease, osteoporosis, osteonecrosis, and the neurocognitive disease where people can think clearly. Finally, and this was actually raised by your last questioner in the last session, is type 4 lupus. What is type 4 lupus? So you ask yourself, well, he's given me type 1, 2, 3. Is that all? That's enough? Is there more? No, not really. There are other combinations, and they are really presentations that are concomitant diseases. They happen in patients with lupus. That is, lupus patients are more susceptible to these conditions. Let me give you some important examples. First, malignancy. Patients with lupus are more prone to have lymphoma, that is a malignancy of the lymph nodes, and leukemia, the malignancy of blood cells. Those conditions, like lymphoma, can give you swollen lymph glands, fever, aching, fatigue. And if you have a patient with lupus who now comes in with swollen glands like this, you can say, oh, it's their lupus, give them prednisone. No, you have to be sure that you're not dealing with the complication of a lymphoma, because the treatment for this would be very different from the treatment of lupus. So think of this as a concomitant disease one of the what I'm calling type 4 lupus. The second one is extremely interesting, and this is one of your questioners asked this at the end of the first talk. The overlap connective tissue disease. Just like you're more prone to certain malignancies, you're also more prone to develop other autoimmune diseases. Once you have an autoimmune disease, you're more prone to have another. One is Sjogren's syndrome. This is the condition where you have extreme dryness in your mouth, in your nose, in your vagina, and you have swollen lymph glands, and you have dry eyes, very dry eyes. Now, this condition can occur in a mild case of lupus. It could be milder in a case of lupus, or could be very, very severe when you've got a full-blown Sjogren's syndrome. Now, the nice thing about this is both of these conditions, lupus and Sjogren's, are often treated with the same medications. So this is an overlap where it's important to recognize it because you'll look at how to treat it better and you'll look to see if it's getting better in the right way. So this is really helpful if to know that there are two things going on. And then you have this condition where the patient with lupus develops clear-cut rheumatoid arthritis. Now, remember, I told you in lupus, the bones don't get damaged. In rheumatoid arthritis, they do get damaged. One of the new biologic treatments for rheumatoid arthritis is not good for lupus. So you have to now decide if the patient comes in with severe arthritis, does this patient have what we now call rupus, rheumatoid arthritis lupus, have two conditions, and which one is manifesting itself most now? Is it the rheumatoid arthritis or is it the lupus? Can I focus in on the rheumatoid and use the rheumatoid medications? Or do I say this is all the lupus and stay with the lupus medications? So overlap syndromes. If you're predisposed to lupus, you're predisposed to malignancy. If you're predisposed to lupus, you're predisposed to other autoimmune conditions. And then finally, the condition that all of us get after a certain age, that's osteoarthritis. Now, the patient with lupus may develop osteoarthritis in some areas more earlier than many of us do, because the treatment damages their bones, and damaged bones give you osteoarthritis. Now, the only reason we need to know that is if a patient comes in, a patient with lupus, comes in and says, oh, I've got this terrible pain in my right knee and in both hips. You have to say to yourself, is this lupus flaring? Or is this osteoarthritis from one of the complications of lupus that we all get and is confusing the diagnosis of lupus? So that type 4 lupus is concomitant diseases, full-blown diseases that occur at the same time and should be highlighted and treated appropriately to get the best results. So that's what I say, what I am calling type 4 lupus. So type 1, acute inflammation. Type 2, I don't know what causes it, but don't use the anti-inflammatory medication. Type 3, these comorbidities have now taken over the patient with lupus who's living longer. Be aware of them, treat them early. And then type 4, be aware of an overlap syndrome that could occur like a malignancy, like concomitant rheumatoid arthritis. Thank you.
Thank you so much, Dr. Murray. Thank you. We have a few questions here from our participant. If I can start reading and if you can help us with your answer.
Sure.
Thank you so much again. So the first one, it says, is there a way to fix the pigmentation after the rash goes away?
Yeah, no, that's, we always call our dermatologists and say, help us get rid of this hyperpigmentation or hypopigmentation. And, they use various light rays, etc. None of them have been very successful for our patients. So that's the tragedy. So what we want to do is treat the acute condition early and not allow the pigmentation or the scarring to occur. It's an important question, but unfortunately, we're not good at that yet.
We have a comment who say for the weak hair, a silk pillow helps protect from loss and breakage.
Yeah, I think it
Wow.
would. And it just, it may come off when the woman goes to, or the person goes to to comb their hair with a brush, they may come off. So if they're prone to alopecia, that means if those hair follicles have been inflamed, they're going to be prone to lose hair. The only thing you've got to do is get the inflammation under control, and there's a good chance that hair can regrow. It's just when you let it go on for a long period of time without treating it that the hair growth is significantly impaired.
Another question, it says, how do you differentiate neurological symptoms in a patient with SLE to determine if they are lupus related or unrelated to the disease?
To what disease? A different disease?
How do you differentiate the neurological symptoms in a patient with SLE to
Yeah,
determine if they are lupus related or unrelated to the
that's a
disease?
very good question. Now, see, now you're getting into the consultant's role, the heavy role. So if somebody has cognitive dysfunction, as an example, can't think clearly, can't reason clearly, the the question is this due to type 2 lupus or is this due to active lupus now, which can give you organic brain syndrome? And here you have to rely on other features at the time. In other words, if the patients have other features, either of central of neurologic lupus or of other lupus like rash or arthritis or serositis, etc., then you say, gee, there's a good chance this is due to lupus. We've got to treat the lupus, but keep a close eye. If everything else is negative and their blood tests are negative, you might say, I really believe this is type 2 lupus and I'm not going to give steroids. But that's a big decision. And you really need a lot of evidence about the patient, the patient's other clinical features and the laboratory features, the antibody studies.
Another question, it says, what does DMPI stand for?
Oh, DIMPI, dual isotope myocardial perfusion study. They inject two different isotopes and then measure the ability before and after stressing the blood vessels. It just remember it as a heart scan.
Yes, thank you. Do you recommend that women with lupus talk with their reumatologist with about having the heart checked out? Do you
Yes,
recommend that?
absolutely. Absolutely. So there are a number of ways to do this. The first thing is just because they're a young woman, don't neglect to order cholesterol, blood sugar, and measure their blood pressure. Don't say because you're young you don't have any. So do it that way. And then if they've had lupus for some period of time, there's really now a good rationale. There are a number of studies like the scan to do a scan or one of the other studies to see could this could there already be signs of early neurologic, early atherosclerotic disease in this patient? Yes, I think that's now going to become part of, you know, this now is a higher cause, atherosclerosis is a higher cause of death than acute lupus in our patients with lupus. So we've got to focus on this. If this was a high cause of mortality, we need to do preventative medicine, treat it early, which means diagnosing it early.
Thank you so much. What treatment do you recommend for type 4 lupus?
No, but type 4 lupus really means which of the types do they have? So if you see the patient and they come in with fever and aching and really swollen lymph glands, I would say do a lymph node biopsy and make sure it's not a malignancy, right? And if it's a malignancy, you have to treat it as a lymphoma malignancy or as a leukemia malignancy, right? So for type 4, you say which is the predominant disease that's manifesting itself, the concurrent disease, treat that. Now, having said all of that, Is it possible that you can have a lymphoma and have active lupus as well? Oh, yes. That's where it gets to be very difficult because you've got to adjust the therapy. Obviously, you want to treat the malignancy if it needs treatment, and at the same time, watch the lupus very carefully. Very often, the treatment for the malignancy may even help the lupus, but you have to keep a very close eye.
Thank you. Another question. It says that I'm 76. I'm diagnosed in 2006. I have a lot of burning soreness, burning sensation. I feel muscle weakening. What can I do? It's asking for any help that you can offer.
No, I mean, I won't do office medicine on the phone. You know,
Oh,
I
yeah.
think we need a
Yeah.
much clearer. The doctor has to see and say, this is, does she have peripheral neuropathy? Does she have other causes for what are called dysesthesias, abnormal nerve sensations? And so then the doctor will decide what is the best approach. Is it a symptomatic approach or is it going to treat the underlying cause? So it, it needs investigation, is what I should say. And when you go in, present it to your doctor. Say, this is what's bothering me at the present time.
Thank you again. Another question. It says that similar to the Ontario Neurology Association, who automatically provide full team support, when the kidney function fall below a certain level, how can we get support from patients who have class 3 lupus?
I'm not sure I understand that. They started with kidney.
So they
What
say
was
when
it?
the kidneys function fall below a certain level, how can
Yes.
we get support from patients who have class 3 lupus?
Well, I'm not sure what support they want. I mean, if the kidney function is below normal, you have to find out what's going on. What is the reason for this? Is it continuing to fall because of active lupus? Is it continuing to fall because they have high blood pressure? Those are the things that have to be discerned by the physician. And that really doesn't have much to do with type 3 lupus. Kidney function is deterioration in kidney function is generally associated with the disease itself, type 1.
Okay, that's clear. Another question, it says, when I start my appointment with a new rheumatologist, should I go by saying I'm sure I have type 2 lupus, or would still bother the average rheumatologist, so I should not say directly like that?
So, you know, I, I always found it very helpful to see that the patient is knowledgeable, and then because then you talk at a different level. So, I mean, bringing something up in conversation, saying, I really can't reason normally, and, I know this might be just a long-term effect of lupus, or it could be due to my lupus. What do you think, doctor? Is it due to my lupus? Do I need treatment for this, or how should I approach it? I mean, you got to do it diplomatically. You want to make sure you continue a good doctor-patient relationship, but show them that you understand what's happening. And that's the purpose of these meetings. I would say this is the same kind of what Laura said earlier. What I'm telling you now could be given to the third and fourth year medical students. The same kind of discussion. So I think educating patients so they can talk knowledgeably to their caregivers is the right thing.
Uh, I have the last question, if it's okay for you, doctor. Do you have any tips for managing skin discoloration from, sorry for maybe spelling this, placanil? Do you have any tips for managing this
Ah,
skin
yes,
problem?
yes. That's no, the only that's due to deposition in the skin, and it's sort of a grayish discoloration that you have, and it's not all that common, but unfortunately, It is a problem for some patients, and the only way is to decrease the dose of Plaquenil. And so, what you have to do is sit with your doctor and say, "Am I on? Do I need this dose that I'm taking now? Could I get by on a smaller dose?" And bring up the Plaquenil discoloration in the skin. The other thing is, the dermatologists are always experimenting with other, not experimenting is the wrong word, but are all using other approaches, different kind of light exposures, etc. And if that's a big problem, and it sounds like for that patient it is a problem, a consultation with a dermatologist might be very helpful.
Yeah, thank you so much. I have just a last comment here. Somebody's saying that for lupus patient type 2 and 4, we need support for dietitians, social work, and this is not offered. So they say that it's hopefully they can offer for this kind of disease as well.
You're absolutely right. And so that's why in our clinic, we worked for a long, it was not easy, but we worked for a long time convincing them that we needed a lupus nurse, somebody to sit in the lupus clinic with us and handle a lot of the type 2, type 3 symptoms. Now, in clinic areas or hospital areas, you can point to other specialties. Diabetes have had diabetic nurses for years. We use that argument. Why are we different from the diabetic people? Lupus patients are as complicated. And so we do have a lupus nurse associated with our clinic now. So you could use that argument. There are many chronic diseases that are associated, that have paramedical workers working alongside with them. And I do believe it's important. Doctors, in somebody who is quite ill with type 1 lupus, they have a full, they can fill their entire appointment dealing with the type 1 symptoms and the drugs that are necessary. So having somebody like a nurse to fall back on to help in the short run or in the long run with the other features is really very important. So I thank you for asking that question. Do whatever you can to see that the clinic area you go to has some kind of additional help to manage the other features of lupus.
Thank you so much, Dr. Mori. Thank you so much for today's presentation.
My pleasure.